In the interim, please welcome Suzanne O'Sullivan.
Okay, so what I'm here to talk about tonight really is psychosomatic illness. So what I want to do from the very outset is explain exactly what I mean by that, because I feel that there's an awful lot of misunderstanding surrounding this condition, and I want to really kind of lay my cards on the table from the start. So what I mean by a psychosomatic illness, because it has lots of different names, is a disorder in which people suffer with real physical symptoms that cause significant disability, but that cannot be explained by physical examination or medical investigations. So I want to emphasize a couple of bits of that. First of all, I'm talking about real symptoms. So when I say that somebody has pain, which is psychosomatic in origin, that sort of pain is every bit as real and every bit as painful to the sufferer as pain caused by disease. So these symptoms, so a psychosomatic diagnosis, when I talk about it here, shouldn't be considered in any way as a dismissal of the severity of the symptoms, because the disability and the distress is at the core of the diagnosis. I also want to be completely clear that I'm talking about something that is an entirely unconscious process. So I'm talking about something that is outside the control of the sufferer. So for example, and this is not a psychosomatic disorder, but if you think of your heart racing when you are nervous about something, that is something which is not happening due to a disease, but neither is it within your immediate control, and neither are you doing it on purpose. And similarly, when I talk about psychosomatic symptoms, I'm not talking about something which is done deliberately, and I'm not talking about people faking illnesses. Finally, I'm going to mention some patients tonight, and this is a diagnosis that I take very seriously, and I think it should be made in the same way as any other diagnosis would be made, after proper consideration. So patient needs to be listened to, properly examined, appropriately investigated to arrive at this diagnosis. So it's not something that's made as a first impression based on a behavior or something in the patient's story. So if I mention anyone tonight, then please assume that they have gone through the process of investigation to lead us to an appropriate diagnosis. Now, my next point is more a disclaimer. You've heard that I'm a neurologist. So I'm trained to deal with people who have diseases of the nervous system, diseases of the brain, like epilepsy, multiple sclerosis, Parkinson's disease, and so forth. So that's what I'm trained to do. I don't have any training in psychiatry. I don't have any training in psychology. Obviously, I've done the same training as every doctor has in medical school and as a junior doctor. But when I began doing this work, I had no special interest or training in psychiatry, and that is still the case. So I need to really explain how I came to be in a position that I am so interested in the disorder of psychosomatic problems. So in 2004, I took my first consultant post, and I was appointed to a job in which a large part of my work was aimed at investigating people with seizures. So most people with seizures will go to a clinic, go to an epilepsy clinic, they'll be treated. Approximately 70% of people who have seizures and receive the appropriate treatment in an epilepsy clinic will get better, and about 30% will not. So a big part of my job was to take that 30% of the seizure population. They were referred to me. I admitted them to hospital to witness their seizures in order to make a diagnosis that would allow us to understand why they weren't getting better with standard treatment. Now, I expected when I did that job that what I would be doing is treating a lot of people with very difficult drug-resistant epilepsy. What actually happened is in the first year of that job, 70% of people that I brought into hospital, I videoed them having seizures. At the same time, we measure lots of parameters like your heart rate, your brain waves, your blood sugar, and so forth. And when we did that, we established that 70% of the people being referred to the service actually had a thing we call dissociative seizures. These are seizures happening for psychological reasons rather than because a person has a brain disease. And just in case anyone doesn't know exactly what I'm talking about, 100 years ago, these people would have been referred to as having hysteria or hysterical seizures. Now, I suddenly found myself incredibly out of my depth in this sort of in this first consultant post. And it really raised a lot of questions in my mind, because why was I out of my depth? Because this should not have been a surprise to me, because it is the normal course of events that for most doctors will see very frequent sufferers with psychosomatic illness. And I had seen many of them in my training. And yet suddenly in a consultant post in which finally everybody was my responsibility, I found myself out of my depth in knowing what I should do with them. And that's really a manifestation of medical training, a problem of medical training. Because basically the way we are trained now is if you're a neurologist, you're supposed to look for neurological disease. And when you rule out, I really need a glass of water if anyone could get me one. And if you're wondering if my voice is psychosomatic, it's entirely possible. It is entirely possible. I did have laryngitis, but it lasted much longer than really it should have, right up until the day I had to do a series of talks. So basically, so the bottom line was that this is a manifestation of training. Thanks so much. As a specialist doctor, you're supposed to look for disease within your specialty, and then when you find that disease, you treat it. And if you don't find that disease, then you essentially no longer consider that patient to be within your remit, and you are justified in discharging them. And that pretty much is how I had been taught to practice medicine, and that is pretty much how most doctors are taught to practice medicine. So I'd seen many patients with dissociative seizures when I was in my training phase, but in those patients, we usually discharge them back to the referring doctor, and I didn't follow them up. But because when you're training, you're moving jobs frequently, you're working for different people, the scope of the problem hadn't been so obvious to me. But now that these people were my responsibility, I didn't feel comfortable with discharging 70% of the patients I was seeing back to a service that wasn't any better equipped to help them than I was. So I became interested in trying to help the people I was seeing. I had very supportive psychologists and psychiatrists that I was working with, and also specialist nurses. And we found that through just learning by our own mistakes, that we were able to help a significant number of people. But those who we could not help, when we tried to refer them on to specialist services, waiting lists for as long as 1 year to be seen in a multidisciplinary team clinic that was appropriate to help people with these kind of psychosomatic problems. And if you consider that these people were having seizures, sometimes 10 a day, so these people who have dissociative seizures tend to have very frequent seizures that last a long time. For someone in that position to wait a year to get the appropriate sort of help is really outrageous. That is how my interest came about, and because psychosomatic disorders are not just seizures. Seizures were the manifestation in which I really first encountered, the breadth of the problem. But as soon as I started seeing people with seizures, then I started seeing people with paralysis, blindness, memory impairment. Essentially, psychosomatic illness can cause any symptom that you can imagine. So chest pain, palpitations, skin itch, anything. So my first interest was in seizures, but eventually I was seeing people with all manner of different physical complaints that couldn't be explained by any medical investigations and didn't fit with any medical diagnosis. So let me now just describe to you a fairly typical sort of patient that I see these days. So Olivia is someone that I met recently. And Olivia was someone who, when she was sort of in her kind of late teen years, finishing school, in her last year of school, she started developing abdominal pain. Now, she went through extensive number of investigations at that time. These went as far as laparoscopy, so looking inside her abdomen and her pelvis to see if anything was amiss. And ultimately, the abdominal pain was felt to be unexplainable. She was not given any specific treatment, but rather symptomatic treatment, and she began taking regular painkillers. A couple of years after that, she began developing bladder problems. The bladder problems manifested first as pain passing urine, and she was told that she had a urinary tract infection. She was treated for a urinary tract infection. She got better briefly, but it kept recurring until ultimately she was put on low doses of antibiotics for a long period of time. And during flare-ups of this pain passing urine, she was completely unable to pass urine, She had to be taught to empty her own bladder by self-catheterizing, so putting a tube into her own bladder to empty it when it was necessary. Now, I met her when she was in her late 20s. She had gone on holidays, and on a wet tile floor, she had slipped and fallen and hit her head. She was okay at the time, and she was seen in the casualty department of the local hospital. But the day after the accident, she woke up and she was paralyzed down one side. A couple of days after that, she began developing seizures. She was extensively investigated in the country where the accident occurred, and then she came back to the UK and was transferred to a neurology hospital to be investigated further. Now, I think people are always concerned that the diagnosis of something like a psychosomatic disorder is something that's made just because the tests are normal, and that perhaps these people have a disease that we simply haven't found yet. When I saw Olivia, it was very clear from the outset that her neurological problem could only have a psychosomatic cause. And there are very strong positive features on which we base this diagnosis rather than just what is normal on the tests. So, for example, if somebody has muscle weakness or has had a stroke, for example, and they're weak down one side, we will see certain features in their reflexes that fit with the very specific pattern of weakness. So brain disease, for example, causes one pattern of weakness. Muscle disease causes another pattern of weakness. So we're looking at patterns of weakness. We're looking at the weakness in different postures, standing, sitting, lying down. Different muscle groups are weak in different sorts of disorders. And we're comparing objective clinical signs with subjective experience of the patient. So if someone is profoundly weak, I might expect something like the reflexes to be abnormal in some way. And reflexes are an objective finding, whereas the weakness is more subjective. So based on these sort of findings and the disparity between what Olivia was experiencing and what I found on examination, it was very clear to me that her weakness was indeed what we now call functional or psychosomatic. In regard to the seizures, it is also easy to make a sound diagnosis if you could see the seizures. So epileptic seizures are accompanied by very dramatic electrical discharges in the brain, whereas convulsions and collapse and loss of consciousness in a dissociative seizure is accompanied by a normal waking EEG pattern. So the brainwave pattern, when you're unconscious for psychosomatic reasons, looks like you're awake. There's only one circumstance in which that can happen, and that is if the unconsciousness is psychologically driven rather than being due to a disease. So it was not a difficult diagnosis to make, but then you've got to put yourself in Olivia's position and realize she's come to me as a neurologist. She's expecting to be told that she had a stroke or a brain hemorrhage or something along those lines. She has absolutely no idea what is about to happen to her, which is that her diagnosis is about to be changed from a brain disease or a brain injury to something psychological. And that's really where the most difficult part of this diagnosis comes in, because it is an extremely stigmatized condition and people have a great deal of difficulty accepting it. And I want to address the arguments that pretty much every patient puts to me when they are faced with this, and most are faced with it quite unexpectedly. So basically, I mean, the first thing that most patients said, certainly Olivia said, is, so you're saying there's nothing wrong with me. So we have developed a language in which we think that if we cannot find a disease and investigations and medical tests are normal, that in some way means that there is nothing wrong. And this is very much the attitude that people have towards psychological suffering. It's like there's nothing wrong with him, he's only depressed. Or there's nothing wrong with her because her tests are normal. I would argue that anybody who's having seizures on a daily basis and has weakness and abdominal pain and self-catheterizes most certainly does not have nothing wrong with them. And yet that is the impression that people get when they're told that their tests are normal and we can find nothing wrong. The other thing that happens really is that we as doctors are not very good at having this conversation. Because I think, in a well-meaning way, we want to make the person feel better, and we have a tendency, when we find that everything is normal, to minimize the symptoms. And it's like what I was saying at the beginning about the pain of psychosomatic disorder being every bit as painful as any other sort of pain. The minute you hear that your problem has a psychological cause, I think that it's like we're trying to make the person feel better through that. But unfortunately, that works for some people. If you go to the doctor and you've got a headache, you're worried you have a brain tumor, most of us would be reassured if we were just told that we didn't and that everything was fine. But unfortunately, when people have more severe disabilities, the minimizing of the symptoms is a really big mistake. What they really want is to have their suffering acknowledged, not minimized. And we have to examine whether Olivia is lucky in any way whatsoever to have had her diagnosis changed from seizures and a stroke and a brain hemorrhage to this diagnosis. Well, if you think about epileptic seizures, I wouldn't wish to minimize them either, because that is also a serious complaint. But 70% of people who have epileptic seizures, you give them a medication to treat it. If you choose the appropriate medication, they've got a 70% chance of going into complete remission. If you have somebody with these dissociative or hysterical seizures, you probably only have about a 30% chance of making them better. Their seizures are more frequent, their seizures last for longer, their seizures are more likely to result in them being inappropriately admitted to the intensive care unit. So in many ways, what I was trying to tell Olivia was that this problem had the potential to be reversed, but that it wasn't a less serious problem. And in many ways, in fact, it was going to be harder to treat. I wasn't going to be able to just give her a tablet and send her home and expect that in a couple of months she would be better. So it is a positive diagnosis in the sense that it has the potential to improve if the person gets the appropriate help. But they must get the appropriate help in order for them to recover. Now, the next thing that Olivia said, and certainly I hear almost every time I discuss this diagnosis, is that people voice the concern that I think or others think that they are doing it on purpose. I can understand why this concern is voiced, because it is extremely difficult to understand how a person could be lying on the ground, unconscious, convulsing, while their brain waves and all their brain parameters are actually telling us that they're awake. So it is very easy, I think, for us to have this misunderstanding, but it's also very important that it be dispelled. And certainly that was kind of a journey that I had to have through medical school and through my training and through the job that I do now, because some of the behavior surrounding these symptoms creates the impression that there is something purposeful about some of the disabilities. So just to give you an example of someone that I've seen who has what we call functional blindness, so blindness for psychosomatic reasons. So this woman is profoundly blind. She had a minor injury, and then she completely lost her vision. Every parameter on her examination is normal. So although she can see absolutely nothing when you ask her what she can see, her pupillary responses are normal. If you do electrical studies to see how her eyes are responding and how the electrical signal travels from her eyes to the visual cortex of her brain, all of that is intact. And there are various other tests you can do if somebody is blind. You can expose them to kind of a rolling drum that has rapidly changing black and white colors, and you can see their eyes following it. So there was many aspects of her examination that said she had the ability to see, but her experience was that she couldn't see. I was a junior doctor when I met this particular woman, and I recall my own struggle with accepting her complete lack of insight, because her behavior suggested she had insight. For example, she would, when she was distracted, she would reach out and pick things up off her table that she couldn't possibly have picked up unless she had been able to see it. But if you asked her, could she see it, she wasn't able to see it. And what happens when a patient does that in front of their doctor or their family or anybody is that we think, oh, she's putting it on, that she isn't really blind. The exact same thing happens with this functional or psychosomatic paralysis. So when I'm formally examining patients, I'm asking them to lift their leg off the bed. They can't lift the leg off the bed. But then when I go back to my desk to write and I ask them to put on their shoes, they begin moving more freely. And unfortunately, when doctors see that, and I think when most of us see that, the automatic assumption is that they can actually move and that this is a faked illness. It's taken me years to come to terms with really understanding the disparity between the patient's examination when I formally examine them and their behavior when they are in more distracted moments. And I've really come to realize that, if anything, that these are acts of complete innocence. They speak to the lack of insight rather than to the insight. So I think that somebody who is pretending to be blind comes to the hospital with their white stick and their dark glasses and makes a play of being blind. And similarly, people who are pretending to be paralyzed, they don't present to hospital multiple times looking for scans, because when the first scan is normal, they simply cannot believe that it was normal, and they ask for another scan. I think in general, people who are pretending to be ill are the people who don't come for the scans, or who are more evasive about their disability and more evasive about being investigated, whereas the behavior of people with these functional disorders is very much a genuine search for an explanation. And in the case of the seizures that I see, most of the patients are much more likely to collapse in front of medical staff than they are anywhere else. So dissociative seizures or hysterical seizures, they happen in the hospital when the patient's being videoed. They happen in the outpatient department. They happen in the presence of medical staff. Again, that can be seen as a manipulation. What that is a genuine cry for help. If you're faking seizures because you want to claim a disability living allowance or financially gain or avoid work, you don't collapse in front of me. You tell me that you're collapsing at home, and then you avoid collapsing in front of the doctor who will actually tell you what's wrong with you. So I really believe that in the first instance, it's tempting to see some of these behaviors as manipulative, but I think the truth is these behaviors are cries for help. If any of you are unconvinced by that and prefer to have medical investigations to prove the difference between faking and being genuinely unconsciously generated disability, there is now proof. So if you do functional MRI, so functional MRI is where you lie somebody in a scanner and you ask them to perform an activity, and essentially it looks at changes in blood flow that allows you know which bit of the brain is activated during a particular activity. If you do a functional MRI scan on someone who is perfectly well and compare them with someone who has psychosomatic paralysis, and then compare them with somebody who's pretending to be paralyzed, you will see different area of activation in the brain of each of those three people. So on a functional MRI scan, pretending to be paralyzed does not look the same as having a psychosomatic paralysis. Now, I think some people misunderstand those fMRI findings to imply that means there is a brain disease after all. It doesn't. fMRI doesn't really mean that. It implies that the brain is not adequately recruiting the motor parts of the brain, and that is something that you can, through neuroplasticity, your brain can be trained to behave differently than other people's brains. So, say, for example, in London, taxi drivers, before sat-nav, they had to have a really encyclopedic, extensive knowledge of the London streets. They had to know every single little street. If you do fMRI scans on the navigational memories of London cab drivers, you will see differences in their brain compared with other people. So that's a function of plasticity. So changes, I'm just make the point that a change in an fMRI scan does not mean that you have a disease, but it does at least allow us to distinguish pretending from other forms of paralysis. Now, the next thing, basically, that always arises in conversation with someone like Olivia is the sort of the how and the why of it. I mean, how is it even possible that somebody could be paralyzed or that somebody could be having seizures? There must be a mechanism. Well, of course there is. And if I could now present you with the exact mechanism, this problem would be solved, because it would be incredibly easy for people to accept the diagnosis. We don't fully understand this condition, but there are certainly lots of examples in our physiology that probably give us really big clues as to how this happens. So one example is dissociation. So we now call hysterical seizures dissociative seizures because we believe that they may be a function of a thing called dissociation. So what dissociation is when your mind wanders off for a moment. So we all dissociate from time to time. So it's when you read a page of a book and you get to the bottom of a page and you realize you didn't take any of it in and you have to read it again. Or if you're watching the news, looking out for a specific part of the broadcast, and then you miss that part of the broadcast even though you were attempting to pay attention. So there are examples of sort of normal dissociation. And we think it's likely that when people have these more extreme blackouts, that may be a function of dissociation also. With regard to symptoms like loss of feeling and loss of sensation and blindness, they may very well be a function of a thing called filtering or gating. So basically, our sensory systems cannot handle all of the sensory information that we're getting. So if we live in a noisy street, we learn to not hear the traffic. Or when you're sitting on a chair, you don't feel the chair underneath you unless you think about the chair underneath you. The same is true for our visual sensory system. So you think you can see everything around you faithfully. You can't. You will see what you're paying attention to. Everything else is filled in and reconstructed by your unconscious mind. And this sort of filtering, gating system is certainly possibly implicated in situations where people lose sensation, so lose visual sensation or lose sensation in the limbs, for example. Another possibility is related to the neuroplasticity of the brain, the way we can retrain our brains. So if you think about sort of sports players, they use psychologists, and you can train your movements. I always use the example of my own tennis playing. I managed to train myself from being a good tennis player to being a really bad tennis player. So basically, when I say good, now I'm probably stretching it a little bit, but in my local tennis club, I was good. And then I started playing squash, and that basically is a completely different wrist action. I played squash for a period of time. When I tried to go back and play tennis again, my tennis game had deteriorated to such a degree that I never got it back. I had retrained my movements in a negative way. And these kind of retrained movements are probably at the heart of how somebody loses the ability to walk, because very often when I see something like a functional paralysis or psychosomatic paralysis, someone's had an injury, and that injury has changed the way they walk, and that injury has made them worry about putting their weight on their foot, and that injury has caused them to avoid doing things. And through these kind of mechanisms, we can kind of retrain ourselves in a negative way. Essentially, I don't want to labor Freud because there's many things I do not agree with, but what Freud said was that basically, if a thought can produce a movement, then why shouldn't a thought hinder a movement? And I think any one of us who's ever stood on the edge of a diving board and tried to jump off and haven't, know what it feels like to have thoughts hindering movements. But that kind of brings me also to then the sort of the why of it. Why would any of these things happen to Olivia or to anyone? And certainly, 100 years ago, when Freud wrote Studies in Hysteria, this disorder was considered to be exclusively something that happened in response to psychological trauma. In the first instance, sexual trauma, but then also to other sorts of traumas. And it was considered to be what a term we still use, a conversion disorder, so that you convert your psychological trauma into a physical symptom. So you essentially consign the psychological trauma to your unconscious mind, so you're completely unaware of it. And in its place, you will develop a physical symptom instead. And those physical symptoms were considered to be symbolic. So in Studies in Hysteria, the cases that were described would be, for example, a woman saw a dog drinking from the cup that she liked to use. And from then on, she had great difficulty drinking water. Or somebody else that was nursing their dying father, and his foot rested on her knee. And after her father passed away, she developed leg pain in the exact spot where her father's foot had lain. So that was very much a sort of, up until very recently, we still kind of thought about it, not quite so symbolically as that, but as a feature of something that only happened during psychological trauma. Now, or in the aftermath, I should say, of psychological trauma. Now, I certainly wouldn't want to dismiss the fact that psychological trauma is a significant causative factor of the more extreme forms of this. So 30% of people who have the dissociative seizures that Olivia had have suffered sexual abuse in childhood. But that, of course, means that 70% have not. So there is certainly a link with trauma. I would consider it less to be a case of conversion, but rather people are aware that they've suffered significant psychological trauma in their lives, and they feel they've dealt with it, or they're not able to feel the pain that goes along with the trauma they suffered, and it manifests as a physical symptom in its place. But I don't think that trauma is the only reason that this happens. And I think that's been an important point for us doctors to learn, because as long as we were dealing with this idea that this was entirely related to a specific type of stress, it meant that we were bombarding our patients with questions saying, well, there must be something stressing you, there must be something traumatic happening in your life, and if you would only tell me what that was, then I would make you better. And basically, we weren't making people better that way. If you could identify the trauma, that was great. But then there was a large proportion of people who just said, listen, there isn't anything. And then basically we thought they were just denying it. I think that actually, while trauma is important, there are lots of other ways that this can happen. The attention we pay to our bodies and the way we respond to injuries or things that happen to us or changes in our body is extremely important. So I'll give you another example. If you don't already think I'm a little bit bonkers, then basically this is another of my psychosomatic problems. So basically I once injured my foot. I broke a bone in my foot, and I had to wear a non-weight-bearing cast, and I wore it for 2 weeks. And when the cast came off, my foot was really wasted. And I'd never had a disability or an injury before, and I was quite shocked by how wasted it was. And I had difficulty walking on it. And my imagination just ran riot. I was absolutely certain that the bone had not healed properly, because I was not very good at hopping on one leg, so I also fell several times during the period I was wearing the cast. So I thought, I've done something else to this foot. And every time I put my weight on my foot, I imagined the bones, kind of separating. And this kind of led to, over kind of a couple of days, a situation where I just did not feel able to walk at all on that foot. And I hopped down to my GP practice, and he arranged an X-ray. Actually, he didn't even look at me. I think he'd already decided what was wrong with me. And he was quite right, as it happens, because I went and I had the X-ray, and the X-ray was absolutely fine. That allayed all my fears, and I walked home normally, essentially. And I think that this is something that happens to lots of people. You injure your back, you think there's a disc out of place, you're afraid to walk, you're afraid to move, you're afraid you're dislodging something. And this is a very common thing in people who have things like functional paralysis, that there hasn't been a major psychological trauma, there hasn't been a death or abuse. That this is actually a manifestation of how they responded to something that happened to their own body. It can be a manifestation of how we perceive our own symptoms. So as neurologists, we would see lots of people with things like tremor. And sometimes when we're trying to assess tremor, we ask people to wear a thing called an actigraphic watch, which essentially just measures the degree of tremor that you have during the day. And when we compare how people have perceived the tremor and how often it's happened during a given day, and then we compare that with how we've measured their tremor, there's often a very big disparity. So some people feel the tremor was there all day, when it was actually only there a small fraction of the day. I find the same experience when I'm assessing sleep. So we would often get people to wear EEG electrodes, measure the brain waves, assess their sleep. We'd ask them how much they slept last night, say they didn't sleep at all, but we would find 6 or 7 hours of sleep. So this can also be a manifestation of what we perceive to be normal, and how we respond to changes in our bodies. It can also be something we learn, particularly if you've had a childhood in which you were kept off school and given lots of love and care and attention every time you were ill, then that may well be how you continue to deal with your own illnesses as you get older. So there's lots of different mechanisms through which this can develop, and it's certainly looking for psychological traumas is extremely important. But if you don't find them, then you have to consider other mechanisms, because they are very frequently the case. So just coming back to Olivia, I mean, what I would do in Olivia's situation is I do refer everyone, irrespective of of what I suspect to be the cause, I will refer everyone to a psychiatrist, but a psychiatrist who has a specific training and interest in this disorder. Because if you send someone to a psychiatrist who only deals with schizophrenia or only deals with depression, they may never have seen this before. So it doesn't need to be seen by people who have an interest and training in it. What unfolded with Olivia was, that we felt that it was likely that in the beginning, when she had problems like abdominal pain, that this actually began at a very pivotal point in her life. She was and is a very bright and successful person. She had a lot of pressure on herself to succeed, and something about being ill meant that if she did not succeed, that there was something else accounting for it. Then, as her life continued, the kind of medicalization as a solution to problems became almost a normal thing for her. Then, when she slipped and injured herself, she had an experience of her body that every time something happened to her, it led to something terrible. Because every time she got an abdominal pain, she ended up in hospital having different kinds of exploratory operations. And she began to assume that every medical thing would be, so she was catastrophizing, really. And that was probably what happened to her when she slipped and hit her head. She thought that this would lead to something else. She thought she would never just get away with it. And it did lead to something else. Now, I've been spending a lot of time talking about quite extreme cases, people who are blind or having seizures or having paralysis. But I would hate for any of you to feel that you're off the hook, because those things are rare, but all of the other things are incredibly common. So I'm not talking, while somebody in the extreme position that Olivia is in or was in, is actually not especially common. This problem on the whole is incredibly common. So studies looking at patients attending neurology clinics show that approximately a third of people who are referred to a neurologist are believed to have a psychosomatic disorder when they're seen by the neurologist. The exact same applies to all sorts of other clinics, so cardiology, rheumatology, etc. In some clinics, the percentages rise to as high as 50%. Pretty much the symptoms can be anything. Dermatologists see this as skin itch, flitting skin rashes. Respiratory physicians see it as wheeze and chest pain. Cardiologists as palpitations and chest pain. Pretty much every doctor sees this in the region of at least 20%, but up to 50% of their daily workload. Fortunately, most people will only be struck down by this for short periods of time. It won't become something that takes over their entire life. But even those short periods of time are usually months at a time and usually involve multiple medical investigations. And that's where this touches us all, essentially, because this is very costly to every health service. So there was a study carried out in the USA in 2005 to look at the cost of this to the health service. And it was estimated to cost £256 billion a year to investigate people with these symptoms. And that's compared with the cost of diabetes, which was $132 billion. And that's particularly bad when you consider that that $256 billion was spent on doing investigations that did not help those patients one iota. It was not spent on getting them the appropriate diagnosis and the appropriate help. So that was, some of the investigations would certainly need to have been carried out, but the repeated hospital visits and the repeated investigations were unnecessary. I should also add that this is not a problem of a particular country or society or health service or economy. There was a World Health Organization study that looked at the rates of these sorts of problems in countries as diverse as Chile, India, Nigeria, Germany, the USA, and they found that the rates were very comparable in every country. So this is something that in some way or other is affecting us all. So what are we supposed to do about it, which I guess is the whole point. I think that there are very clear places where we really need to change. First of all, we need to change in medical schools. The bottom line is when you're a medical student, you spend your whole time searching for diseases and learning about diseases. So when you're a medical student, you go around hospital wards essentially mithering nurses and doctors to point you in the direction of the interesting patients who have diseases and signs that you can learn from. And obviously that's something you have to do. You're going to need to recognize those things in the future. But when you encounter patients who have just medically unexplained symptoms, they have nothing to teach you. And from that point onwards, they become patients that are very easy to dismiss. And despite the fact that this problem is taking up about a third of most doctors' workload, the vast majority of us have no training in it whatsoever. So even the most well-meaning doctor, struggles to know what they should do about this problem. It's treated as what is referred to as a diagnosis of exclusion. So you go to your doctor with seizures, and that doctor then spends the next 6 months to a year trying to figure out what your seizures are, treating them, not making them better, and only at the end of that do they start considering alternative things. But at that stage, you've been having seizures for so long and have been invested in the anxiety and worry of having a brain disease that it's much harder to reverse the process. Similarly with things like chest pain, we spend a long time ruling out heart disease before we say, well, could it be something psychosomatic? I think this diagnosis needs to be considered as an equal diagnosis. So if I'm having seizures for this reason or this reason, they're both equally important and should both be investigated from the beginning. So someone doesn't have to wait 2 years to find out what's wrong with them, only when you've ruled out all the other things you think are much more important. Despite the frequency of this problem, it's very rarely represented and underrepresented in medical journals at medical conferences. So as I've told you, at least a fifth of people in epilepsy clinics having seizures actually have dissociative seizures. But until very, very recently, if you went to any of the major epilepsy conferences, either here or in the UK, you would not see this subject discussed. And yet it was at least a fifth of the workload of every epilepsy doctor in the room. So we need to start taking it seriously as a problem and giving it the same level of research and attention in medical journals and conferences as we would any other cause of a medical problem. But once again, I don't want to let you guys off the hook, because the bottom line is where all of this, the biggest problem lies is in the stigma against this condition. And I don't think I don't want to blame doctors entirely for all of the faults here, because I think society really does not regard this problem with any level of respect. I think, if one of us had a workmate who, suddenly was in a wheelchair, were off work for a prolonged period of time, and we thought that they had multiple sclerosis, we'd have a large level of sympathy for them and a large level of understanding for them. If we then learned 6 months later that the problem probably isn't multiple sclerosis, but actually that this problem is entirely psychological, I think, if we're being honest, that most of us would have a sort of mindset change in which we would suddenly see that person differently. And that is one of the biggest reasons why people resist the diagnosis. They don't want to have to go back and tell their families and tell their workmates and tell their insurance companies that they do not have what they thought they had. They actually have this other problem, which is largely disregarded by society. So I think we all really need to change our mindsets so that we see that people who suffer with physical symptoms for psychological reasons are suffering. They can be made better. And that almost is the most important reason to pay more attention to this problem is if we did pay attention to it, a lot of these people would not become permanently disabled. Thank you. Okay, thanks. I have one here. So I think we're going to get questions, and I believe that anyone who wishes to ask a question needs to approach. You are approaching.
So, how do you treat psychosomatic illnesses, number one? And number two, are there things we can do to avoid developing psychosomatic?
Yeah. I think, the treatment I utterly neglected. I apologize. It's extremely individualized. So it very much depends what the disability is and how it came about. So obviously some people have suffered a significant psychological trauma. Those people will need to see a psychiatrist and a psychologist to deal with those issues. But if you have somebody who has a predominantly physical disability like paralysis, that has come about through an injury and response to an injury, that person doesn't need years of psychoanalysis or discussion of their psychological well-being to get better. That person needs to unlearn the fear and avoidance that created their disability, and what they need is a really good psychologically minded physiotherapist. So it's really, we need to create MDT, multidisciplinary teams that deal with this in the same way we would any other disorder. So people with physical, predominantly physical disabilities need to be given physical therapies as well as getting psychological support where needed. And with regards to what we do about this, that is an extremely difficult one. I mean, you don't want to ever dismiss any symptoms, and I dismiss my own all the time. I'm sure I'll come a cropper someday, but basically, you don't want to dismiss your symptoms, but you have to be able to accept reassurance. And I think that's the main thing that people need to do. And that doesn't mean you have to accept reassurance from the first doctor you see. Some doctors, you know, if you feel you haven't been properly listened to and you haven't been properly examined, then by all means, I would always ask for a second opinion if I wasn't happy. But when you find yourself getting to the point where people keep offering you reassurance and you're now on your fourth or your fifth search for an opinion, then that is where this situation can go downhill. Another question?
Thank you. Wonderful talk. Two questions. One is there any relationship between this thought process, psychosomatic, and the placebo effect? Secondly, in terms of interventions with practicing clinicians, how many, the percentages are so high, between 20 to 50%, as you say. It seems like some number of hours, even this talk has opened my eyes, could cause them to get way down the learning curve. I mean, is this something that could be transferred, this set of insights, this mindset, in some number of hours versus days or weeks or months of training?
Oh yes, I think this would be very easy to introduce. I mean, as soon as, you know, the potential was there, then when I wrote a book about this, the potential was there for other doctors to be sort of disparaging in some way of it. But actually what's happening is the doctors are very relieved that somebody is actually making suggestions. I think it would take very little, but I think it needs to start in medical schools so that we change the mindset of medical students, really. But I think it would take very little to change how doctors deal with this. And the main thing they really need to do is just consider this as an equal medical problem and not as a diagnosis of exclusion. Yes, with regard to the placebo effect, absolutely. I mean, they're similar processes. You know, if you can believe yourself well or you can believe yourself unwell, and placebo is certainly beneficial for some of these patients. I don't formally prescribe placebo, but placebo is what doctors are doing all the time when they say, you know, I don't think this is anything for you to worry about and you'll get better in a few days. So yes, I think placebo is very useful for this, but I prefer to try and really understand the mechanism of it in the individual so that it doesn't happen again.
Very interesting. I have partial seizures. A doctor of mine suggested, rather than, as soon as I have the aura, to immediately do mathematics. And if you constantly do it, and then if you do it, the aura stops, I will not have a seizure. But if I stop in the middle of the math and I still have the aura taking place, I will have the seizure. So it's sort of distracting my mind is what I'm doing. Yeah. And then there are also those people who lose a limb and they have pain in that limb. Yeah. But if they look in a mirror, they think they see the limb and the pain goes away. I'm just wondering what kind of distraction we're talking about here.
Yeah, I mean, they're unrelated phenomena, but I mean, I'm an epilepsy specialist. I will believe anything of epilepsy because it's an incredible disorder. The most bizarre things trigger seizures, for those who don't know. So, for example, there are seizures triggered by thinking a certain thought or eating a certain food or movement or hearing a certain piece of music. So therefore, it's entirely reasonable to suggest that you can potentially temper your seizures by doing something similar. With regarding to things like phantom pain, that's a little bit different because that's really, you've lost the limb, but the bit of the brain that's serving that limb, you didn't lose that. And that reorganizes itself, and that sometimes is the cause of the pain. So the brain is just an incredible organ, and we understand so little about it. So they are interesting phenomena, but I think they are separate to this. Hypnosis basically is used for this, actually. I mean, hypnosis has fallen out of favor because people are very suggestible during hypnosis, and that caused a lot of problems in the past. And therefore, there's ethical issues. However, there are places where hypnosis is used, and the way it's used is if you've got somebody who's got functional blindness or paralysis, if you hypnotize them and make them suggestible, you can actually get them to walk under hypnosis. There's also drug abreaction, where they give drugs like propofol at very low doses that make you suggestible, and they make paralyzed people walk, video them, and then when they're no longer under hypnosis, show them the effect of it. Now, that actually is miraculous sometimes, because you can actually just cure people that way. The other thing you can do is traumatize people that way. So it's sort of, it absolutely works, and I wouldn't sort of counsel entirely against it, but there's a lot of issues there as well.
Yeah, you mentioned a lot about the diagnosis by exclusion,
Yeah.
and the 6 months to a year where they're trying to eliminate all the symptoms or all the possible problems. But that's a really tough problem, right? Because, you know, like, nothing would be worse than diagnosing somebody with a psychosomatic disorder that could be treated by, you know, some sort of medical intervention. So I was wondering, do we have any idea about how we could go about that, or any sort of strategies at this point?
I mean, the important thing is that, you know, I investigate someone for a psychosomatic problem simultaneously. So I see someone's seizures, I investigate them for epilepsy simultaneously with this, rather than just focusing on epilepsy for a year, because it takes an awful long time to figure out if someone has epilepsy or not. So you can spend years doing it. So I will basically focus on both possibilities simultaneously in the first instance, so that the physical disease-related things won't be neglected. But I think, you know, we're very comfortable neglecting this and leaving it as something on the back burner for later. But a lot of harm is done by leaving it on the back burner, because the longer it's there, the harder it is to treat. I'm not sure I understood every bit of your question, but the other point that it raised in my head, I don't know if this is what you were asking, is about the stability of the diagnosis, because you're quite right. Doctors are terrified of telling you that this is what they think is wrong with you, and therefore they do not tell you for that reason. They suspect it, but they're not telling you. Now, I met a doctor the other night who said that she'd seen a young woman who had paralysis, and she suspected this was the cause, but they were investigating her for strokes and things, but she never told her. Now, if I saw a person who I thought had a stroke and I didn't tell them, you'd be outraged. You'd say, why would you keep that from them? So why are we keeping this diagnosis from people? Well, I know why. A, because people get bloody pissed off when you tell them, and we have to find better ways of telling them. So if it's less of a dismissal, people will get less angry. And secondly, because we're terrified of missing a disease, which I think is kind of what you were alluding to. We, as doctors, are terrified of missing diseases, because that will make everyone very angry. And I worry about it all the time, that I'll say something is psychosomatic, and then it will later turn out to be a disease. But the consequence of our reluctance and our fear of missing disease is that we are utterly neglecting this other problem, which is an extremely serious problem and leads to serious disability. So I think if we regarded this diagnosis as equal, then missing this should be considered. You know, I often see people who've been told they have epilepsy for 5 years, and then I tell them they don't. And they prefer to just keep the diagnosis of epilepsy, because it is so difficult to make the switch over. So I think, yes, and the stability of the diagnosis. In neurology, if the diagnosis is made properly, the misdiagnosis rate is about 4%, which is the same misdiagnosis rate that you'd have for any medical problem that doesn't have a kind of single evidence of a single diagnostic test. I don't know if that even remotely answered your question. Yeah. Okay, I answered a few questions. I just chose my own questions.
Thanks. You not only kind of increased my understanding of this, but you also kind of increased my sense of compassion for the people who have to go through it. The whole mind-body thing, I think, is pretty interesting. Another question was about Ramachandran's thing with the mirror and interrupting the whole phantom limb thing. Yeah. That whole mind-body thing. So even if it's not caused, if it's not a psychosomatic cause, it's kind of interesting to think about ways that you can kind of subvert the mind to end up with some sort of a cure. One thing that interests me is like autoimmune disease. I've been prone to a bunch of them that were life-threatening and not too much fun. And I kept thinking, there's got to be some connection between mind and body here. And I tried every alternative thing I could think of, apart from all my list of specialists, to try and figure out some sort of link that I could work with between the two. But I'm wondering if you have any comment about autoimmune disease and mind-body connections.
Just regarding mind-body in general, I mean, what needs to happen is we need to have better links between psychiatry, psychology, and physical medicine. We have in the UK, all hospitals have what we refer to as liaison psychiatrists. So that's someone who kind of bridges the gap between mind and body, essentially. But they're massively overworked, and they don't have even remotely the amount of time that they would need to give to people. So I think we need to improve our health services by bringing psychiatry as a specialty together with neurology in particular, but with all the specialties. And there are people who do that. Gastroenterologists do it very well because everyone kind of recognizes the link between emotional upset and changes in one's bowel habit more easily than other things. Dermatologists, we have a lot of psychodermatology clinics because I'm not suggesting that psoriasis is a psychosomatic disorder, but anyone who suffers with psoriasis will tell you that it flares up incredibly when somebody's under stress. So we need to link these things better. And with regard to autoimmune, this is the point at which I always say, if you brought rotting vegetables with you to throw at me, this is the time to get them out. Because basically, the problem with autoimmune problems is that they are ridiculously, massively overdiagnosed. Basically, there are certain tests that are very difficult to interpret, and autoimmune tests are one of those. So when I send off autoantibody tests, you often get back positive tests that actually mean very little, and they do not mean someone has an autoimmune condition. But there's a lot of doctors out there who put that positive test together with an autoimmune diagnosis. So there's a huge number of people who have autoimmune disorder diagnoses that are simply incorrect and that probably do have psychosomatic conditions. But with regard to someone who actually has an autoimmune condition, we know that stress hormones affect our immune system. So why shouldn't they cause flare-ups of autoimmune disorders? So when we produce cortisol, etc., in response to stress, that changes our immune system. So it certainly would be reasonable to think someone with an autoimmune condition would get better and worse with regard to how their mental well-being was. That's the same for most diseases. Everyone, asthma, diabetes, epilepsy, everyone who has any of these things will tell you that they get worse during times of stress. So we need to address that in everyone, not just in psychosomatic disorders. Okay, sorry, I'm losing.
Okay. Well, I am in fact a dermatologist, and I would agree with much of what you say. And also that autoimmune disease is overdiagnosed.
Good, that's good. Well, that's a good story. You can never quite tell.
But I have a suggestion. Have you, in terms of treatment, used NLP, neuro-linguistic programming?
I don't have personal experience of it, but I certainly know people who have experience of it who do recommend it to their patients. So it's not something that I personally know a lot about, but I certainly think that that's a route that is definitely worth considering. Have you used it?
I've studied it quite a bit.
Oh, right.
And I'm struck with, well, neuro-linguistic programming. It's something that would be too complicated to explain at this moment. However, I think the idea that a third of people might have these non-functionally based problems, okay, kind of goes along with what I've seen in the NLP community, that there are many amazing recoveries that take place. And I've always been a bit skeptical of the frequency in which that takes place. And so perhaps I can reconcile that with the fact that if a third of conditions are somewhat functional, that perhaps that's why they get better
Yeah.
so frequently. And then I'm extrapolating that perhaps this is something that would help many of your patients. Yeah, you can. They fit the NLP model of a inner traumatized part that is creating symptom as a cry for help.
Okay. Yeah, I mean, I certainly I agree that it is likely to help. And the point is really that this is amenable to being reversed, and that there's lots of different ways that it can be reversed. But thank you very much.
Yeah, so I would suggest that as an avenue
Okay.
for
Thanks.
future treatment.
So if a third of us being seen by physicians maybe have psychosomatic illness, are we all sort of susceptible, do you think?
Yes, absolutely.
Or are some people more susceptible than others? Is there any evidence about family tendencies to have psychosomatic illnesses?
I mean, we're all susceptible. We all have what we call somatic symptoms, so physical symptoms in response to psychological things. So every time you get a kind of racing heart or shake in your hand when you're nervous, you're having a somatic symptom. It's only a disorder if it disables you. But the question really is, so who are the people who then get disabled? There isn't a type of person, but there are people who are more susceptible. So people who tend to have anxious personalities, people who are neurotic or who are prone to depression are more likely to go on to develop disability in the face of this than other people. But the reality is I've met many people who have never had depression or anxiety, so it can happen to anyone. It's a threshold, so you just need something to push you over that threshold. So if someone who has never been an anxious type person suffers some significant loss that is sufficient, then that person could develop this. But it does tend to be more likely in people who have a tendency to anxiety. I think there was some other part to your question.
Well, maybe familial basis
Oh,
of
yes.
it. Is there a tendency?
Yeah, there isn't like a genetic familial basis, but there is a kind of learned behavior basis. So a lot of important things happen when you're a child, and if, there's lots of different ways it can happen. If the way that you got the most attention when you were a child was that you were sick, then that something can continue into adulthood. Or if you were exposed to a parent who was chronically ill when you were a child, then that may be how you manifest distress later. So it is something that runs through family, not genetically, but more behaviorally.
To your knowledge, have there been any twin studies of?
I'm not familiar with any twin studies, sorry.
Just really quickly to your point, I have always wondered if a bit of, if we've lowered the threshold of everybody, just how the way we live in disconnection to nature, internalizing all the bad news on the radio all the time. I wonder if it's just over time
I
kind of
think you're
lowered
probably
us.
right. I mean, I'm not sure about the nature part, but I think
I've been pretty
that
sick since the
No,
elections.
I think we have lowered the threshold. I think you're right, because basically it is so much easier to explain things that are, problems in your life, or to deal with things by being ill than being psychologically upset by things. So it is much, we now are much more comfortable blaming our life's failures, I'm afraid to say, on medical problems than we are on reality of our lives, basically. So I think possibly our thresholds are quite low. Having said that, though, I mean, this was prevalent throughout time. So that's not to say that it's a modern problem. 100 years ago, this was also extremely prevalent. The only difference between now and then, really, was the attributions. So now we blame it on electricity pylons and allergies. And, 100 years ago, they blamed it on the fast pace of life. Neurasthenia was a condition which people took to their bed for long periods of time, and that was attributed to them having literally exhausted their nervous systems to the point through, the busyness of modern living. So we do like medicalizing our problems now, but this has been a problem that's been around a long time, and we just change attributions more than anything.
So I wanted to thank you for all the work you're doing. through a personal experience with a back injury, I came to be a believer
Yeah.
after reading the
So
work
easy.
of John Sarno.
Right.
It was very helpful. And so I work in a field where there's a lot of manual labor and there's a lot of back injuries
Yeah.
and muscle injuries. And
Yeah.
so my question, kind of my route to go about it has been, I see someone, they don't get better for a while and they've kind of tried all of the things, you know, before surgery, slip them a John Sarno book and say, try journaling and meditation or something. But I'm curious, especially with a lot of people without access to health insurance and doing manual labor, are there some more or better ways to go about it earlier in the process, resources or ways to start?
I think, you know, probably the best thing is, I mean, you know, what people in that circumstance really need is, you know, a really great physiotherapist. But if you're talking about people who don't have insurance, then that's a problem. There's some very good websites. There's a website called neurosymptoms.com that explains everything that I've just told you and that people often find very accessible in terms of explaining how these disabilities develop. Sometimes you don't really have to do anything, but allow people to understand what's happening to them. I see people with seizures, for example, and I explain what's happening to them in terms of things like dissociation, and the following day their seizures are better. So sometimes it's just understanding it. So you're slipping people a book is a perfectly legitimate thing that is not that different to what I'm doing. But other ways are to look at specialist websites, like, and I would recommend neurosymptoms.com.
Great. Can I ask a small follow-up question? Just around back pain in particular and MRIs, because they, the link between having a slip disc and you hear about it on an MRI and...
Yeah. I mean, unfortunately MRI scans is another abused thing. Basically, it's an abused investigation. I've forgotten the exact statistics, but the number of MRI scans for brain tumors, for example, that are actually abnormal, or for people who think they have brain tumors, have headaches, and think they have brain tumors that actually show brain tumors, is something ridiculously negligibly small. But the minute you do an MRI scan, most people, if I did an MRI scan on the neck of everybody in this room, and I sent it just randomly to a radiologist, most of you would say some osteoarthritic change, some slight displacement, because you just don't get MRI scans back that say this is a completely normal scan. It just doesn't happen. We don't know how to deal with our modern technology, because most of the doctors, including myself, who are working now, trained before MRI scans and before all these autoimmune tests came out. And we get these MRI scans back, and basically I challenge you to go and get an MRI scan with a completely normal result and then send it to me. Basically because it is extremely, MRIs are very open to interpretation and lead to overdiagnosis.
Good evening, and thank you for presenting to us as well. First, wondering what you can comment on regarding psychosomatic allergies. Second, I know a woman who seems to have an allergic reaction each time that she eats anything other than mango, brown rice, and rice milk.
Yeah.
So I'm wondering if that, granted no other context, would fall within
And she's here tonight. No, just checking.
the potential for a psychosomatic approach. Thank you.
Yeah, I think basically, there's going to be a theme to my answers, which is that allergies are overdiagnosed. You know, I've met many people who say, you know, if I eat this kind of vegetable, you know, my bowel motions will change. And I say, like, really? That's such a surprise. Of course they change according to your diet. And these kind of changes in our body in responses to food and things now are being attributed to allergies. Obviously, there are people who have deathly serious allergies, but there are a hell of a lot more people who believe they have allergies that probably don't. And there are a lot of people who are making a huge amount of money off those people. So if you, again, would like to go out and get some allergy tests, even if you have no symptoms, they'll find some allergies, basically. I counsel against excessive investigation because you will ultimately get a diagnosis even if there isn't any disease present. Sorry, I'm...
Hi, I'm Gala. Let's see if I can actually word this how I was thinking it. As you were speaking, I was kind of thinking about when you're talking about brain disease diagnosis versus a psychosomatic diagnosis, it kind of reminded me of the difference between guilt and shame, and how with guilt there's a step removed. We say, I did this, and then with shame we say, I am this. And even when we were talking about like, she is catastrophizing, it made me think about how like, what if we changed the language to, my brain is catastrophizing, or something like that. And so I'm just curious to hear your thoughts about like changing the language around psychosomatic diagnosis.
Yeah, I tell you what, I do have strong feelings about that, which is basically the only thing that has happened to hysterical seizures in like 150 years is the number of times its name has changed. So basically what happens is it's hysterical seizures were very, very, they were kind of extremely frequent during a period in the end of the 19th century because of a French neurologist who became interested in them. And at that time, they were considered to be a brain disease, and they were called hysteria, and that was considered to be a good diagnosis to have at the time. And then somebody changed that diagnosis to mean that it was actually a psychosomatic problem. And once you change the diagnosis, the name of the problem became problematic, and hysteria then became an insult. And since then, they have been called pseudo-seizures, psychogenic non-epileptic attacks, functional seizures, dissociative seizures. What actually happens is that you change a name and people say, oh, dissociative seizures. I can tell my boss that, until everyone finds out what dissociative seizures are. And then dissociative seizures just becomes the next hysterical seizures. And basically, I think what we have to do is, my colleagues don't, not all, I'm in special interest groups with this, and I know that some of my colleagues would feel that yet another name change is, and I'm just as scathing when it's said in a formal meeting. I just think we got to stop changing the names of these things, and if we made it a more respectable diagnosis, then we wouldn't need to keep kind of hiding it in new terminology. Sorry.
You talked about this really high percentage of whether it's 20% or potentially 1 in 3 people encountering something like this. So not to discount those people that are clearly having 10 seizures a day or these more extreme cases, but what about maybe people in this room, such as myself, where it's on the lower scale of that, more pedestrian, more acute situations? How do you differentiate this kind of more severe psychosomatic versus what a doctor might diagnose you in the first 10 minutes? PTSD, depression, anxiety, here's a pill for you. I had viral meningoencephalitis. It's an acute viral condition for 14 days. But then all these things we've been laughing about for the last 10 minutes about, chasing a diagnosis vertically via either neurology or gastroenterology or cardiology. I'm guilty of all those things, having gone for allergy testing, colonoscopies, MRIs of the brain, which could have been, adenoma of the pituitary. So I am just one of the many people that, has been going through that system. What sort of accountable care, like in the US, we talk about kind of that merging of, neurologists, psychologists, the accountable care model where those specialists who are very well educated work together to come to that kind of gray area. How do you, is that a good answer for this?
I think basically, with regard to what you said first, when I'm talking about kind of 1/3 of people and the breadth of this problem, I'm talking about people who have these somatic symptoms sufficiently that they have to take, long periods out of their life sick. So I'm not just talking about the thing that we all get. I think everybody at some point, has had some physical symptom that, a headache, just going through a stressful period in their life. So I think the kind of little ways, it's almost everybody. But the 20%, 30% are people who've actually had significant disabilities. I think that basically it's very hard to tell someone when they should stop looking for a disease. That's why I say we should look at both things simultaneously, and we need to have more of a multidisciplinary approach. And I think if you find yourself in a situation where you're going from specialist to specialist to specialist, getting lots of tests and it's endless, then I often say to my patients, well, look at, to someone like Olivia, I say, well, look at what happened every single other time you pursued these physical symptoms endlessly. You had loads of invasive tests, you ended up on some painkillers and some antibiotics, and you weren't any better. Now can you just change your mindset for a moment and for 6 months try this other way. And just ask people to stop medicalizing things for a while and take a more psychological approach to it.
Just a quick question. Isn't it also an insurance issue as well? If I have epilepsy, it will be covered. If I have seizures and I don't have
Absolutely.
epilepsy, is it just?
Oh, I mean,
just-
the kind of the social issues that surround this are absolutely huge. I mean, it's obviously I work in a different healthcare system to her, but basically it doesn't matter what healthcare system you work in. You will be regarded differently by social services, insurance companies, employers, if you change your diagnosis from epilepsy to dissociative seizures. So people will, in the UK, they will potentially find it harder to get the benefits that they had been getting, have more difficulty with their employers. So there's absolutely a lot of reasons why people resist the diagnosis that are very, very sensible. But that's why we have to legitimize the diagnosis so that it's considered a real problem, and then that wouldn't be a problem in the future. Okay, I think I'll end before somebody else stands up. All right, thanks very much.